Spastic legs. General features. Stiffness or heaviness is more suggestive of upper rather than lower motor neuron weakness, i.e. spastic paraparesis rather than peripheral neuropathy. The causes of a spastic paraparesis are listed in Table 14. Patients with weak legs will often have walking aids or wheelchairs next to the bed. There is often coincidental sphincter involvement, so a catheter bag may be present. Take note of the patient's speech during introductions. If it is slurred, then the patient may have multiple sclerosis, cerebral palsy, one of the rare genetic conditions, or motor neuron disease. While you are shaking the patient's hand, also have a look to see if there is wasting, motor neuron disease, or ataxia, multiple sclerosis or genetic conditions, in the hands. Look for signs of surgical or traumatic injury along the whole of the spine. NB. Beware bladder dysfunction, as this implies interruption of S2-S4, either centrally, spinal cord compression or conus lesion, or peripherally, cauda equina lesion, pelvic pathology, or autonomic dysfunction. Neurological examination. Motor tone will be increased in the leg muscles, particularly the extensors. This results in an increase in tone on rapid flexion at the knee, a spastic catch. There may be clonus at the ankles, which is best tested with the knee flexed. Power will be reduced in a pyramidal pattern, i.e. extensors less affected than flexors in the legs, indeed the extensors may be strong. Deep tendon reflexes will be brisk. If the weakness is severe, then coordination will be difficult to assess. Plantar responses will be extensor, unless there is concurrent peripheral neuropathy, e.g. subacute combined degeneration of the cord. Sensory. There may be a sensory level if the sensory tracts are also involved, but they may also be spared, e.g. motor neuron disease. NB. Vitamin B12 deficiency may cause a peripheral neuropathy but may also result in additional corticospinal tract and dorsal column degeneration, leading to combined upper and lower motor neuron features. The clinical picture can be variable, but remember that this is a treatable condition and must not be missed. NB. Although demonstrating a sensory level points to the spinal cord, it is notoriously inaccurate at localizing the level of the pathology. You should therefore use all possible clinical signs to help you. For example, a patient with a sensory level at the umbilicus, T10, who also has brisk arm reflexes is likely to have a lesion in the cervical cord above C5 rather than at T10. The significance of this is that it is the cervical cord that requires imaging, not the thoracic cord. It is generally much better to start imaging at the top, cervical, and work down, rather than the other way round, Fig 10. Gait. In routine clinical practice and in PACEs, always ask the patient to walk, giving whatever assistance is necessary. The examiners will stop you if there isn't time and they want to start asking questions. The patient may walk with a spastic gait which, if severe, becomes scissoring, i.e. legs crossing over each other as the patient walks. Further discussion. An acute onset or an acute deterioration on a background of a chronic progressive story is a medical emergency and should prompt urgent imaging of the spine. A more slowly progressive onset can be investigated less urgently. Remember that bilateral cortical lesions affecting the leg areas of both primary motor cortices can cause a spastic paraplegia. This is classically associated with a parasagittal meningioma.